So my pleasure to introduce the next speaker, very good friend of mine. Proud to say this, Dustin Grooms is a professor in the Division of Physical Therapy in Ohio University, Athens, correct? Specialized in orthopedics and neuroscience. So his work and research is to understand how the brain and movement mechanics change after musculoskeletal injury and develop therapy breakouts to improve patient or athlete's function via neuroplasticity. So Dustin has more than 100 peer-reviewed publications, numerous presentations at conferences, and is the world leader in this research area. Dustin, a pleasure to have you here.
Thank you, Mario, and thank you for the opportunity. It's my first time in Switzerland. You have a truly beautiful country. Maybe I'll stay and not go back after Tuesday in America. This is our lab, so I'm in sort of the Midwest. This is the middle part of the United States. We're on the border of the Appalachian Mountains. So if you get a chance to come visit the United States, I encourage you to come by our lab. We're in a blue area, if that helps, if you know what that means. So I always love going after Francesco because he really sets up a lot of what I'm going to talk about. Normally I have to spend a good bit of time trying to defend this idea that an ACL injury may cause neuroplasticity, may cause a brain injury. I'm always happy to speak to a physiotherapist, not only because essentially I'm a rehabilitation clinician in the United States, but when I speak to orthopedic surgeons, they're always very shocked. They always think the ACL is just like a rope that connects the bones together that they can just repair and everything is great. But every time I present, most of the time physios will be like, well, yeah, this sort of makes sense, and you sort of feel this in your patients. And so I hope I can give you some things you can actually take and use in the clinic at the end. I don't have any conflicts of interest. I don't take money from any company or anything like that. A lot of my work is funded from the US government, so hopefully it still exists over the next few years. I won't have many jokes, political jokes. I'm getting them out of the way now. So what I'll talk about, I'll go over a little bit how your brain changes after this injury and how neuroplasticity occurs, and sort of give you an update on what the latest in neuroscience is telling us. We're really in, as Francesco was saying, a spectacular time. If we think of where we've come from, it's only been 100 years, and the very first neuroscience experiment was someone would lay on a perfectly balanced table, and they had you do math problems, and the table would flip, it would seesaw towards your head, because you get a little bit of more blood flow towards your brain when you engage in cognitive activities. That was 100 years ago, and now today, I can map down to a square millimeter in your brain what is going on. So in a pretty short time, we've come a long way, and really amazing that this conference is the brain in sport, because as Francesco was saying, we're really at the very beginning of this phenomenon of sort of revolutionizing how we approach orthopedic pathologies. But the classic way, and what inspired me to do a PhD and study neuroscience, was this phenomenon of secondary injury. I think in rehabilitation, we are uniquely susceptible to being invested in our patients. I know in the United States, physicians spend on average 2 to 3 minutes with their patients, and they have to go very fast. But as a physio, you'll spend a great amount of time, or any sort of clinician that actually has to get the patient to recover. And this is always a challenge, because you'll get vested in your patient. You want them to do well. You see them for hours a day over a long period of recovery. And to have them get injured again, I think, is utterly heartbreaking, and it's very difficult to deal with as a clinician. And so I never thought I would do a PhD. I thought I would just be a clinician. I just wanted to help people. I thought it was a fantastic opportunity. And I was rehabilitating a soccer player, a football player, and I thought I did everything right. I did all the tests I was supposed to do, and 2 weeks after he goes back to play, he tears his other side on a non-contact injury, very similar to that Francesco showed us. And then you go into the medical literature, and you're like, well, what did I do wrong? And you try to figure that out. So you go in, and I look into literature, and I'm like, oh, if you go to some of the best places on the planet to do your rehabilitation, you got like a 1 in 3 chance of failing if they want to go back to their same level sport, and they're a young, high-risk athlete. So these data are from the Delaware Oslo cohort, they're from USC in the United States, and they're from some of the Swedish registries. So you have this massive data sets, you have some of the centers of excellence for orthopedics. This is as good as they're doing, so this is sort of disappointing. And then more recently, there's been a couple of studies, and this first one was done in American NCAA Division I collegiate athletes, so pretty high-level athletes. And this finding is sort of shocking and disappointing, so I'll go through it with you. For every 2.1% increase, you have a 2.1% increased risk for a second ACL injury, with every 1% increase in quadricep strength and hop symmetry if you want to return before 8 months. So this is probably the ultimate demoralizing point you could have, because your whole entire job, or at least what I was trained to do, was to you must recover range of motion, I must recover strength, this must be everything. If I can recover the quadriceps, then I have a chance that the patient will do well. And then what you see with the data is that you do your return to sport test and you think everything's going really well, and it doesn't actually protect your patient at all. So you would think if I did exceptional rehabilitation, they would have a much lower injury rate. So what this tells us is that after 8 months, something else in the physiology is recovering that maybe we're not assessing or not intervening on, something that recovers with time. And this was from a very large registry in Sweden where they had over 800 athletes. And what was really interesting about this data, it's very similar. So as you're stronger in the quadriceps, you have an increased second ACL injury rate. And what was interesting about that data is they actually normalize for exposures. So one critique would be, well, maybe my strongest athlete, my best person, they maybe just play more. They're starting, they're one of the best players. They actually had enough data to control for that phenomenon, and they actually found that doesn't matter. You're still at a higher rate. So what this sort of means is that our return to sport test, there was an excellent question to Francesco's, oh, how do I assess some of these neurocognitive elements? And that's what we'll talk about over the next 30 minutes. Which begs this question, what are we missing? So when I decided to leave clinical practice and do a PhD, I started in biomechanics. It's where the field sort of was 15, 20 years ago. And if you go into the literature, if any of you have the displeasure to do a PhD, I don't know if I'd recommend it, be very certain you want to do it. You'll spend a lot of time reading, and you'll realize sort of biomechanics has answered a lot of the questions that biomechanics can answer. But it doesn't really tell us how we're generating movement. And this has been the focus of our lab over the last 15 years, where we try to bridge this gap between our understanding of the physics of movement, the biomechanics, and our understanding of how is the nervous system actually generating movement. And the technique I use is called neuroimaging, or fMRI. So we use a specialized MRI. This allows me to sort of map the brain activation strategy down to a square millimeter. Now, within a millimeter, you could have 100,000 to 1 million neurons. So it's still an imprecise technique. But the 3 individuals who won the Nobel Prize for the breakthrough in the 1980s, this has still given us a great information. Because without this, most of the techniques to understand what brain regions were doing relied on you getting shot or a railroad spike through the head and just seeing what happened after you lost that region. So this is a bit of an advance on our prior methods. And as Francesco explained, so I won't belabor the point, when you look at these injury events, this is sort of your first clue. It's sort of spectacular that we sort of have to have this discussion still, that the injury event itself is a neurophysiological one. If you just see them, you're like, well, in hindsight, after you see Francesco's talk, you're like, well, of course, this is some sort of nervous system error. It's as if her foot was just a few centimeters more medial, she could probably withstand the load and she probably won't have an injury. And we see this over and over again in these elite level sports where a player, I sort of find it hard to believe that they just lacked, 10 Newton meters of glute strength, and that's why they failed. It seems like, why would your nervous system allow your body to go into a position where it's going to rupture? So he's essentially inflicting a self-injury when you have the capability to avoid it. This is sort of an interesting mystery. And then when you treat these patients, they come out of surgery and you have this arthrogenic muscle inhibition. So the muscles shut down. It's also sort of a bizarre phenomenon. The muscles are totally fine. The nerves to the muscles are fine. But the ligament has a similar common input at the spinal cord level. So the spinal cord is expecting a certain level of information to come from the ligament to help you inform motor control. That's now missing, and so the spinal cord causes an immediate reflexive shutdown of the musculature. So you have in the injury event itself, neurophysiological in nature, the response to the injury itself, neurophysiological in nature. So when you first think how we organize movement, this is commonly how movement is taught in neuroanatomy. You may think, well, maybe I plan movement here, and then I execute movement here, and that's maybe all I really have to worry about. And a lot of this is because our techniques to measure the nervous system for a long time were very limited. They were made on this isolated approach. What we now know today is that to move, you actually engage your entire brain. And if you go with the evolutionary biology approach, we were evolved or created, your choice, doesn't really matter, to engage in the world and to move. Is when you fail to be able to move, that's when you're probably not going to survive. And so most of your nervous system is tailored around this idea of facilitating movement and interaction with the world. So when you go to make your motor plan, you actually pull information from every part of your brain, what you're seeing, what you're feeling, what you're thinking about, what you're hearing, and then everything from sensory cortex all the way here to V7, late stage visual cortex, all of this is trying to integrate where are you in space proprioceptively. So proprioception, ability to know where your joints are without seeing them, right? So most of you, probably all of you, could close your eyes and you could touch your fingertips together, sort of a miraculous thing. What's sort of amazing with that phenomenon, and one reason why robotics has taken so long, is that they rely on computer vision and actuators, where your entire body is covered in proprioceptors, telling your nervous system where you are in space without having to use vision. If you see a robot move, or if you watch the Tesla event or Boston Dynamics, any of these amazing robots, they all move just a little weird, right? They don't quite move like a human. It's because they're not covered in sensors to the degree that you are covered in sensors. So whereas we humans have this smooth, fluid motion, they're relying on computer vision entirely to move. It's going to be a little clunkier, not quite as smooth. And we dedicate so much of our hardware to integrating where am I in space proprioceptively, where am I in space visually. And so all that information comes together in your premotor cortex to generate your motor plan and then down to your muscles. And so if you take nothing from my talk today, I just want you to reflect on what does your therapy look like for this step. So picture your clinic, picture how you're prescribing where the athlete is placing their attention, picture how you do your exercises, and now picture their sport. And then do you think this neural organization step looks the same? It's probably not. And I'll give you some ways you can try to address this problem. Now that you kind of know how nervous system generates movement or organizes movement, it's important to think about the neuroplastic effects of the nervous system. And so when we first learn a motor skill, you get this fantastic sort of almost near one-to-one relationship where the areas that control that region will start to expand. So within actually just a few minutes of learning a new motor task, you will expand the area dedicated to that task. So this was a great study that did balance training. And what you have is that the sensory motor areas for the hip, knee, and ankle started to increase. So the number of neurons dedicated to that region would expand as they learned that skill. Now, a key for this is the task had to be very challenging. And so you cannot have someone just balance and have them make no errors. So the key for this neuroplastic phenomenon to have this motor learning effect is they had to be very on the cusp of making error almost constantly. Because if you do not, so this is on this board, and you can sort of dedicate how tight this is, how difficult this is to keep stable. So that is a vital component. So think about your rehabilitation. This is the art of physiotherapy, where you have to keep them on the edge of not able to do the exercise, and you have to walk that line. Because if you're not there, you're wasting your time neurologically. Now, if you exercise enough and you engage in those activities, you'll get an increase in what we call functional connectivity, where the regions of the brain will improve their communication. Now, when I say functional connectivity, this may sound like a complicated term. It's really very simple. It's just it's a correlation of the activity of two regions. So what you're seeing here, you have your frontal cortex and your parietal cortex. This is where you would link what am I thinking about and where is my attention with what am I feeling. And as you learn a motor skill, as you learn the errors, what the errors sort of feel like as you're learning, this could be anything. Learning to play guitar and you hit the right chord, learn to hit a golf ball. The activity will increase in those two regions and they'll start to activate together. So it's simply a measure of correlation. One is perfect, they activate seamlessly. So like the hand area of your sensory cortex and your motor cortex will be very close, it'll be like a 0.8. But then as you get further apart or as the regions don't communicate very often, it's a lower correlation. Now, if you go a long time, you do enough training over time, you develop what is called neural efficiency. This is sort of your gold standard. This is what you want to have happen. This is when you require less brain activity to do the task. And so what you're seeing here, this is a Brazilian study where they looked at elite-level karate athletes, and they used EEG to measure brain activity. You have non-athletes, fencing, and karate athletes. As you can see, our non-athletes require a great deal of neural activity. Red and white is high activity, blue is low activity. So for a karate athlete, they're extremely neurologically efficient to just stand on one leg, because they can stand on one leg and do sort of spectacular feats. Whereas a non-athlete requires most of their neurological horsepower just to stand on one leg. And what's interesting, in football, we see the same phenomenon. This was done in professional versus amateur footballers, and they were told to just move their ankle in the MRI. When you see someone who is new to football, they require a great deal of neural activity to move their ankle. A professional footballer will require less. So you have this initial stage of motor learning where you increase activity, and then you get connectivity of the brain regions, then eventually develop neural efficiency, where you require less activity, and this allows you to handle all the complexity of the world and engage in more complex activity. Now, Francisco presented a lot of interesting data about the non-contact injury events, and I use this as an example that you must have neural efficiency for movement if you're going to be successful in especially a complex sport. He gave very excellent data on you have this time to change your motor plan in order to avoid an inciting injury event. Now, if you're going to rely only on reactive capability, so you sort of have two components to neural control of movement. What's spectacular about your cortex is every column of your cortex, so the cortex is organized in all these cortical columns. They're all trying to predict the world. So your auditory cortex is trying to predict what you're going to hear. Your motor cortex is predicting what you're going to do, and on and on and on. And whenever you have a violation of those predictions, that's when you get this massive cascade of neural activity and you try to correct for it. So as long as your predictions are always accurate, you're pretty neurologically efficient. But if you're trying to respond, if you don't have good predictions of the world, if you're in a new environment or something unexpected happens, you rely on a reactive component. And so the fastest you could probably react is about 50 milliseconds. That'll be driven from the spinal cord. So if you have very good spinal responses, you could probably, all of these could be avoided. This person's probably not, has no hope. If you have a little bit more time, you can engage in a rapid cortical response. So this is how you're able to engage. If you're ever walking down the street and you sort of roll your ankle and you're able to flip it back, you're able to avoid that sort of phenomenon. So that's called a transcortical response. And then you have direct conscious responses where you decide to make the update. But then as you add complexity, every sort of decision option you have, you see about a 50 millisecond further delay. So if I have just one option, I can react pretty fast, maybe 200 milliseconds. But as I add sort of complexity to it, now it requires a little bit more time. And so this speaks to this vital problem where you must have neural efficiency to move. So your job as the physiotherapist is not only to recover the musculoskeletal system, but is to try to make their nervous system more efficient so they can have as fast a response as possible. And so if we look at what happens after injury, in red is ACL and in blue is a control, and all they're doing is doing a very simple motor task where they just extend their knee and come back. So they're engaged in a very simple knee flexion extension task, mostly a quadriceps task. And as you can see, our ACL patient in red, they have a lot more brain activity and it's sort of widely dispersed versus our matched control patient in blue. So you can already tell our ACL patient has essentially lost neural efficiency. Now, what was interesting about this cohort and all the data that I'll show you is that they are all returned to their sport. So I was very interested in what is going on in this patient that I feel like I did everything right for, and they still went on to get an injury. I wasn't so much interested in those that are really struggling. I was mostly interested in those that we seem to do everything physiotherapy tells us to do, and they still had a re-injury. And so in our first study, we sort of found a few key regions that changed. One was the primary sensory motor cortex for that involved side. So these were, in this first study, they were all left ACL, so this is the right sensory motor cortex. So they required more neural drive from the cortex to execute this very simple motor task. The negative of that is you can only increase motor cortex activity so much. So as my motor cortex activity scales up, it's supposed to scale with complexity of the task. But if I'm already higher just to move my knee, now if I add complexity, I'll hit my ceiling. You can only increase M1 activity so much, and then you'll make a sensory motor error. You all probably felt this whenever you're learning a new motor skill. You'll sort of hit this point where you just fall. So if you ever try to learn to ski, or you learn to play guitar, or you're learning to skateboard, whatever you're trying to figure out, especially as you get older, you'll rapidly hit your ceiling where you just can't handle the complexity of the task anymore. And then over time, efficiency will bring that down, and you can get better at the motor skill. Concurrent with that, we found that the cerebellum actually decreased in activity. And so we would really want the lower extremity to be cerebellar driven. So right now I'm able to stand up here and talk to you and walk around the stage, and I don't have to dedicate hardly any of my cortical horsepower to maintaining my upright stance. I can just rely on my cerebellum. Cerebellum is sort of a miraculous structure. It's extremely dense with neurons. You have more neurons in your cerebellum than the entire rest of your brain. And it allows me to just stand up here seamlessly, and I don't have to dedicate any sort of intellectual horsepower to maintaining my stance. But normally your legs are highly regulated by the cerebellum. And we see on our ACL patients, we see this exchange where they're using more cortex and less cerebellar activity. The last region, this region has shown up a few times now. This is a region called your lingual gyrus. It's a cross-modal region. It's in that third of your brain that's trying to regulate where am I in space proprioceptively with where am I in space visually. And the lingual gyrus is a little more biased towards vision. And so what we think is happening, you have this insult to proprioception. So now the lingual gyrus is coming online, and it's trying to give the motor cortex information about where you are visual spatially. Now, if you remember Francesco's talk, he talked about how their visual spatial awareness seems perturbated in these ACL injury events. So after the injury, you're actually compensating with that neurophysiologic mechanism that allows you to engage in the world. You're using it just to control your knee. And we've done a series of other studies now where we find, after in our ACL patients, the connectivity from these sensory regions that integrate vision and proprioception, they cascade out to change how they're connected to frontal regions that regulate your attention. And so when I started all of this research, I sort of thought, well, it's probably the injury event. You lose proprioception, and then your brain starts to rewire. But actually, it's starting to look like it's how you use attention after the injury is causing a lot of this neuroplasticity. And so I want you to start thinking about what your rehabilitation looks like after these injuries. Then if you go long enough, we just finished some more advanced neuroimaging studies using diffusion tensor imaging, where I can map the very structure of the brain. And what we find is that the nervous system changes its very connections. So what you're going to see here, this is an ACL brain, this is a control brain. The neurons connected to the motor cortex of our ACL brain are much more dense. So it's almost like after the injury, the brain is reaching out into the rest of the cortex trying to find more connections. It's going to make you much less neurologically efficient. And so we've published a lot of studies over the years now seeing this sort of whole brain neuroplastic effect after these injuries. And really what it comes down to is that you have this perturbation to the expected sensory input, and then the brain starts to draw from other regions, starts to steal from visual spatial resources and attention regulation resources to control your knee. And this is partially why you get that immediate inhibition. It's hard to recover muscle strength because now you have a different neural organization strategy. And then why we see these injury events when vision is distracted. Now, let's look at your therapy. So, if you've treated patients, I know I've done this once, I've done 1,000 times. Once they come out of surgery, you're like, all right, we're going to get your quadriceps back. We're going to get your range of motion back. And you stare at your knee for hours a day, for months at a time. But especially in a youth athlete, if you think about it, they probably look at their knee 30 seconds their whole life. If you tried to go back in time when you were like 13 years old, before you knew it was called a tibia femoral joint, you knew what a patella was. At that time, you probably didn't think about your joints very much, but what do we do in therapy? We have you think about them constantly. And then if we look at how you're supposed to use vision, the study is very interesting where you have the purple line is where their visual attention is. This is from John Mathis's lab, and then the blue target is where their vision is. You don't actually use vision even to program where you're going to place your foot. You're about 2 steps ahead on average. And so you're using short-term visual memory. The visual memory comes into your occipital cortex, and it kind of sits in your precuneus, in the parietal cortex. And then if your proprioceptive system tells you, yeah, that's where my visual memory told me the ground was, then everything works fine. It's only when he sort of stumbles a little bit on an unstable rock where vision rushes back, and he tries to make a correction. And like Francesco showed, you have Georgette's video here, where visual attention is on anything but their joints, but yet most of our therapy allows attention on the joint itself. And so we're training essentially a neural strategy that doesn't really transfer to sport very well. And so to overcome this problem with Greg Meyer, he was at Cincinnati Children's Hospital, we developed this virtual reality simulation where this allows us to sort of take sport into the lab. What's great about VR is you can standardize the protocol. So every single athlete can have the exact same perturbation, and I can see how do they move in this virtual sport. And the key to moving well in the virtual sport was to have neural efficiency of your motor cortex. So we tried to figure out, well, what's the neural activation strategy that allows an athlete to handle the complexities of the sport environment? And the primary driver of it was improved neural efficiency of the motor cortex. So when you think about prescribing your exercises, you need to think about it that it's more than just the exercises you want to do. Not only do you have to have them on the verge of creating an error like we talked about, but you must also think about where you're placing their attention and how can I add a sensory or a cognitive challenge that'll better simulate sport. So if you take nothing from today, I would encourage you to think about where you place their attention during the task. One thing that we've recently done is trying to encourage a cerebellar activation strategy. So in this case, trying to remove their attention, we tell them, just keep this rectangle a perfect rectangle. And what the athlete does is they move, and if the rectangle will deform based on their movement pattern. So if their knees collapse in, the rectangle deforms a little bit. And then if they load one side more than the other, rectangle deforms. This is called implicit learning or implicit biofeedback. This encourages a cerebellar strategy. So you may look at this and you're like, well, this is very fancy, this is very nice. I don't have a full biomechanics lab or augmented reality to execute this. But you can actually simulate this. So when you're with the athlete, you just try to give them that's good movement or bad movement. So you try to give them feedback without telling them exactly what you want to do. So you can be very creative as a clinician. You want to sort of trick your patient to move how you want them to without telling them. So you can use metaphors. You can be very simple and just be like, good, not so good when they're moving, and have them try to self-discover or program how to move. This is how children learn to move. When a child learns to walk, they don't go, okay, I need to do hip flexion, knee extension, dorsiflexion to the ground. That's not how they learn to move. If anyone has children, that would be ridiculous. So we're trying to encourage a very similar sort of self-discovery of motor control. Sort of a hybrid approach would to just use external focus of attention, where you put their attention in the world. And so instead of having it on the joint itself, you essentially achieve the same movement and you put it on the external environment. I'm sure Anna Benjaminis will talk more about this. She's been a leader in this area of motor control and learning. And I talked before that it seems like that it's how we prescribe rehabilitation that induces a lot of this neuroplasticity. And we have this ongoing longitudinal study where it looks like the first thing that's changing early after injury is not the sensory processing, but it's your cognitive and attentional processing. So the very nature of how you prescribe rehabilitation is probably driving a lot of the data that I've showed you. You can also use some very simple virtual reality scenarios. We recently developed an app. It's free to download. It's on Android, though. It's more complicated to make an app for Apple phones, where you can, essentially, we do different scenarios in VR. So they're doing their soccer kick. They do a soccer kick when they're engaged in a very basic straight leg race, so they can't see their knee, a little more engaged. As they progress, we do balance training under different virtual reality scenarios. This throws a visual error, makes them rely a little more on proprioception. So we're trying to target these different neural aspects with different perturbations. And we use very simple sort of smartphone, easy to use virtual reality scenarios. In this one, they're landing from a jump. They think they're on top of a building. So we're essentially trying to use clever ways to induce a mismatch and where they think they are visually, where they actually are proprioceptively. And so you could probably think of other clever ways to do this once you have this idea where I need to do this mismatch of visual attention. Another tool we use a lot is stroboscopic glasses. There's a lot of companies that make this tool. It's pretty cheap now, where you can essentially perturbate visual processing. And so I'm trying to downweight your reliance on vision and make you use more proprioception. And these glasses essentially shutter in a way that you can customize, so it can be a little more aggressive or a little easier. You can also use cognitive challenges. So Francesco spoke to this a little bit. And ideally, like Francesco talked about, well, it's not sport. We want to have sport. And he's absolutely right. That is ideal if you can do it. We've done a series of studies now where you can simulate a lot of the same demands of sport with simple neurocognitive challenges. You actually get a similar number of motor errors if you just have them add these as they jump and they're just flashing on a screen that you get when their attention is on a sport activity. You're just trying to control their attention and cognition and not let them use that to compensate. So you can use virtually anything you want, flashcards. You can be very creative with this. My last couple slides will speak to return to sport tests. So I know there were some few questions on this earlier. Our classic return to sport tests were focused on jumping. How far can you jump? We published this study, and we put a lot of work into this. This is in JOSPT. This was sort of trying to get the last 15 years of research in like 3 pages to make it as easy as possible to implement a lot of the techniques we've done. So if you pick up any article, I'd encourage you to check. Maybe this one would be the one. And when you design your return to sport test, you want to think about how can I customize this test to have these attributes. So the first one is try to make the environment more challenging. Try to incorporate some sort of reactive component. So as we talked, it seems reaction time or the processing speed seems important. Incorporate inhibitory errors. So there must be an opportunity for them to make a wrong decision on the test. You want to have an intentional error potential during the test. And then you want to look at their movement quality. Were they able to maintain the same performance, or did they have more valgus or loss of movement quality? This is probably the test that we've had the most success with. So the athlete has a go signal, that's peripheral vision, so he has reaction time here. Then he has to jump as far as he can 3 times. Which side the go signal is the side he has to jump to first. And then he has to stare at this light during the jumps and tell me the colors. So we have sort of all 5 components. You don't actually have to have the lights. You could just stand in front of people and say, here, you're going to jump, and then you're going to add the numbers as I flash them to you. So this avoids their ability to look down and see where they're going. And then it forces their attention the entire time on the environment. And so this is a simple way. You take your standard test and you just add this augmented layer and see how they perform. You can know if they're ready. So things to think about when you're designing your return to sport test, to try to have a reaction component. So do your baseline test normally, and then add this layer on top of it. You must have a cognitive error to start, an attentional error during, and then you monitor their performance. So I know I've given a lot of options. What I would encourage you to think about is take your standard therapy, so design it how you're always going to do it, and then just think about what can I add to each exercise to augment it. Some exercises are very good for VR. VR is kind of clunky still to use in the clinic. Some exercises are better for a dual task. Some exercises are better for other modalities or other tools. So just go through your therapy and try to have an option for how can I target some of these sensory processing issues, and then hopefully you have a better result for your patients. So I've gotten to work with a lot of amazing people over the years, so I thank them for that, and I believe now if there's time with questions. Thank you, Mario. Thank you, Sue.
Thank you, Dustin, for always fascinating presentation, and congratulations, great Swiss timing.
Very good.
Great. So, Susan?
So do you have any questions in the audience? Yeah?
Yeah, thank you for your presentation. Very nice for clinical tips. I have one question about this neurocognitive test, like the HOP test.
Yeah.
Have you assessed the reliability of this test? How do you interpret the result when you do it?
So we published a few studies on different reliability of a lot of the tests that we presented. So in the paper, we present many options. So I just showed you the one test, and that triple hop test, the one reason why I like it the most is it incorporates like every aspect of the perception-action coupling. And there's some data that the triple hop may be a little more sensitive to secondary injury risk in pediatric patients. So we thought, well, we'll target this test and we'll augment that one. It has pretty high reliability, and our reliability measures our reaction time from the go signal, and then their hop distance, and then their attentional error. So how reliable is that? We've done it in healthy and our ACL patients. The reliability is good. What we find for our ACL patients is that they usually have about a 10% drop in their hop distance under the neurocognitive challenge. So they jump 100 centimeters without it on the normal baseline condition, and we see most of our ACL patients drop about 10% of that, so 90 centimeters less. A normal healthy person, though, this is important to keep in mind, you'll have about a 5% degrade. So you'll know you're outside of what would be a normal degrade in performance, because you're always going to have some degrade. It's a lot more challenging of an exercise. And so I think if they're above 5%, you know they're in this sort of not quite optimal range. And then we find those that are greater than 10% is those patients have a lot of lingual gyrus activity, a lot of frontal cortex activity. So you can use this test as like a window into the brain where you don't have to scan their brain. So you know they have more than this 10% drop, then you know that they are probably over-relying on neurocognition.
Just one dumb question, maybe.
Please.
But if they fail the cognitive task, is it considered as invalid and you redo it? Yeah.
So we only have them redo the test if they can't stick the landing. Otherwise, we keep the test and we record the cognitive errors. So we're trying to see if the cognitive errors are predictive, because you have this idea of like task prioritization, where some patients, they'll be like, well, I'm going to jump as far as I can, but they'll fail the attention part where they won't look at it and they won't be able to remember the colors. We haven't found that to be as sensitive for secondary injury or some of the other outcomes, but we definitely record it, because as a clinician, you want to interpret that data. So you have a patient come in and they're like, wow, they had no drop in their performance and the cognitive, they must be doing real well. But then you're like, oh, but they had cognitive error every single trial. So we use that more as a clinical point to interpret the data. We haven't seen that be as predictive yet. It's a good question.
Thank you.
There was another one there.
Hi, thank you for presentation.
Thank you.
I'm Gaëtan, a physio in Geneva. I had a question regarding increased cortex activity with ACLR patient. Is it also the case with the contralateral leg? And if so, does it give a part of explanation of contralateral injury?
So you repeat the question?
So about increased cortex activity when moving the leg, is it also the case when they move the contralateral leg?
I see. Yes. So we don't see much of the sensory neural processing changes. So in the involved leg, we see a lot of the parietal cortex changes. A lot of that we think is due to the disrupted proprioception, that sort of cascade of events. For the uninvolved leg, we see an increase in frontal cortex activity only. And so we think the uninvolved leg is still going to have this shift in how you're using attention to control your body, but we don't see as much of the sensory-related neuroplasticity, which sort of makes sense. So we think the uninvolved leg changes similarly from the behavioral intervention, where you're dedicating a lot more attention to your lower extremity in general, and that cascades over a little bit to how you control your uninvolved leg, your contralateral leg as well.
I have a very short question for you from the audience. What's the name of the Android app?
Okay. So it's not available on the App Store if you're looking for it. What I can do is, if you email me, I'll email it to you, but maybe there'll be a lot of emails to respond to. So if you want, I can leave it to Mario. Mario could link it. So there's a link on our web page. It's kind of hard to find, though. Our university pages are kind of weird, but you could post it.
Okay.
And essentially, you would click the link on your phone, and it'll download the APK, and it's very beta version. But what it'll allow you to do is you can select exercises, and basically everything we've published, so we have about 10 different VR scenarios we put in the app, and you can make the difficulty more, so you can go faster, slower, drop it in a viewer with your phone and use it. I'm kind of hoping some company would just buy it, because we're not like app developers as a lab. We just did it on the side to try to get our work to make it clinically usable. But I think that's what we'll do.
And I have another question from Slido, from the audience. What's the role of strength training in the neuroplasticity context? How can you enhance that also? Like, what could you add something to your strength training to make your brain?
So a lot of strength and conditioning professionals will have, like when you're doing, you always have a mirror when they're doing like squats and different exercises, if you think of a normal strength conditioning environment. What a lot of, I think, strength coaches are doing now is they sort of take away the mirror. They'll have a curtain in front of the mirror. And so you might do your warm-ups without visual feedback. And so you try to minimize it during those activities. And then when you're doing like maximum exercises, you might give them the visual feedback. In a physiotherapy context, what we do mostly, so say you're having them just do like knee extensions on a machine. We take a very basic strength training exercise. Before I'll increase the weight, so you say the patient does very well, that they did 3 sets of 10, very easy, whatever you're prescribing. I'll usually add a cognitive challenge, and I might use flashcards. I'll be like, okay, you're going to execute a quadriceps extension on even answers and hamstrings on odd. And then I'll stand there, they have to respond to me, so they have a reactive start, and they have to execute the movement. And if I find they struggle a little more, like if they can't lift up the weight as easily, or it's more challenging, then I'll do maybe one session with the cognitive load, and then I'll take it away, then I'll make the physical exercise harder. So I sort of interject these cognitive challenges in my strength training with our patients, because I want them to be able to execute a movement with high strength, but not have to dedicate all of their attention to it. And so you just think about, I'm going to do this attentional manipulation, and you just sort of leapfrog it, where before you increase the resistance, I might add this sort of neurocognitive resistance first.
Thank you. Is there any live question? Yeah.
Thank you so much, Dustin. We were talking about ACLR. Does it apply to also other ligament injuries?
Yeah, so I believe Susan will talk about shoulder later today. So there's been an interesting body of literature exploring this neuroplastic phenomenon from orthopedic injuries. We see very similar results in ankle sprains You see it in shoulder. What we see, most of the shoulder stuff has to do with apprehension, though. So if the patient's in a fear state, you see this cascading alteration of neural activity. And the ankle is actually probably even more interesting. So they have developed chronic ankle instability. The ligaments are a lot higher innervation. So the ACL is only 3 to 10% mechanoreceptors that form where your knee is in space. You actually rely a lot more on your muscles for the knee, because the knee is sort of this open position, right? Versus the ankle is very stable. And you might argue that the ankle has even more of a neurophysiologic phenomenon where you're going to get this shift in neural activity. So I think you could apply these principles to most any joint, not just, it's not like the ACL is not neurophysiologically special. It's just one reason why we study and research, it's a very homogeneous injury, whereas a lot of the other injuries are highly variable, so it makes it for a good model that you can apply to other injuries.
Thank you.
Great. So many thanks.
Thank you. Thank you,
Dustin,
Mario.
you're here all day. You can approach Dustin.
Thank you.
So now it's break time, and make sure you'll be back at 11. Enjoy the break.